Today on Health Stories Speak, we have Dr. Puneet Ahluwalia, who is Director of Uro-Oncology and Robotic Surgery, Medanta Hospital, Gurgaon. Welcome, Doctor.
Thank you, ma'am. Thank you so much.
Dr. Ahluwalia treats concerns of genitourinary tract, which includes kidney, bladder, and prostate, etc. He's one of the first fellowship-trained robotic surgeon in India for treatment of urological urological cancers in India with more than 10 years of experience. He's also a proctor for training new robotic surgeons in the country. And he also has many publications to his credit. And he is on the regular faculty in national and international conferences on the subject. We are very grateful for you, Dr. Ahluwalia, to spare your time to talk to the viewers, because I think today's topic, as we agreed, will be prostate cancer. And if I could share, we had on the channel 2 patients actually who've gone through robotic surgery talk about prostate cancer. And it's really, I think, a big concern among men, and that particular people want to know more. There were questions on this. So if we could begin by asking you, how prevalent is prostate cancer, doctor? And what are the symptoms, if any?
Thank you so much, ma'am, for having me. So, prostate cancer is one of the most common cancers in the men, and it is actually the second most common cancer to affect men. And the story is same worldwide. In India, it is no different. Uh, we, according to the census, we had around 35 to 40,000 new prostate cancer cases diagnosed last year, and this incidence is increasing. So, because of the awareness, because of the screening, because of the better facilities, by 2040, it is predicted that this incidence will be somewhere around 65 to 70,000. So, we need to know about this. So, there are no specific symptoms of prostate cancer, especially in early stage. So patients can have symptoms of lower urinary tract symptoms, which may be there even in benign enlargement. As the age progresses, the prostate size increases, and patient can have some symptoms like getting up and going to pee again and again in less than 2 hours, or getting up in the night and having frequency of urination, or the stream of the flow of the urine is low. But these are, general symptoms. These are not specific to the cancer. So especially in the localized stage, early stage, when we actually need to diagnose it and treat it, at that stage, there are no symptoms. But at the later stage, when it has spread outside the prostate or the other organs like lungs or liver or bones, you may have bony pains, you may have cough, you may have, lumps or lymph node enlargement in the body. So that is not good to have, because at that stage, it is already spread to other organs, and we talk about control and not cure. So no specific symptoms, but yes, you should be aware of it. How you can come to know about it? Just talk to your doctor. There is just one screening test, a blood test of PSA. The doctor will advise you whether you should do it, at what age you should do it. Regarding that, we can discuss about it as we go further.
Okay. So would you say there's a certain age that men should definitely screen or get a PSA test done? And how often do you think it should be done? At the moment, there's no cancer, but just to screen.
Yes.
Yeah.
So this has been subject of great interest in last few years, and there have been various controversies also whether you should screen at all or not, because the PSA testing started in 90s, and suddenly after 1990s, we saw a great increase in incidence of the prostate cancer, logically because of the more screening. But at the same time, we saw that even the very early grade cancers were being detected and treated, which led to over treatment and side effect of the treatment. So we need to avoid that. So that caused the controversy, and then some guidelines from the American, preventive US preventive task force came that you don't need to screen at all. But in today's date, the guideline is that you screen the patients between 55 to 70 years after discussing with them that what is the benefit of this screening, and once the if the PSA is raised, then what tests you need to undergo. At the same time, if the patient has a family history, or the patient is from some region like not in India but African patients, so those patients or family history in which family history is positive, those need to be screened at early age of 40 years.
Oh,
And yearly PSA, or if the risk is low, then 2 yearly PSA is good enough.
okay. So that's for the screening. But what if,
Right.
suppose, in the initial screening, if the doctor is suspecting something, what are the different tests? I personally heard of uh, PSA or a PET scan, or
So
yeah,
one thing before going for the test, we should know that having a raised PSA is not confirmatory of cancer. What in an average person, we take a PSA of 4 as a cutoff, but
right,
we can have benign conditions like infections, inflammations, or urinary retention. And if we do PSA during these, situations, then PSA may be raised, and we need to wait for 4 weeks with antibiotics and then repeat a PSA.
right,
But there are some cancers in which PSA is not raised at all.
right,
But these are exceptions. But once you have ruled out these benign conditions, or there's no infection, and you have a raised PSA of more than 4, once repeated also it has come as more than 4. So then the next thing to do is an MRI prostate,
oh,
along with the clinical examination, which is called digital rectal examination.
right,
So now we do MRI prostate before biopsy, because it guides us also in which first it guides us what is the probability of having a suspicious lesion. There is a scoring, so that, and also it helps us in guiding the biopsy,
right,
from where to take the biopsy, which region to biopsy. And sometimes what happens is that there is a very small focus of cancer, so we can do a MR guided biopsies also, MR fusion biopsies also.
right,
Then we do a biopsy, which is usually a standard is a 12-core biopsy. We do it through transrectal route, but now we are doing it through transperineal routes also. This is the normal biopsy, 12-core extended biopsy, but otherwise MR fusion biopsy in some situations we do, in which more extra cores of lesions which are seen in MRI are taken after fusion of MRI. So the diagnosis is confirmed on biopsy only. So
okay,
if you have a situation where PSA is raised, and you have a suspicion on which on MRI that there is a suspicious lesion, but your biopsy can comes as negative, which can happen in 10% of the patients. With false negative rate is 10%. But if you have this situation, then you need to decide whether how much PSA is raised,
right,
and what is the how much suspicion is there in MRI, what is the family history, and if you have a high suspicion that this patient is likely to have a prostate cancer, but it has been missed on the biopsy, then you need to do a repeat biopsy. If
right,
original was not an MR fusion biopsy, and then you do a MR fusion biopsy. But if suppose we say that 4 is cut off and patient is having PSA of 5, and MRI is showing Paret's 3 or Paret's 4 lesion, and there is no family history, then you can wait for 3 months or 6 months and do a repeat PSA, and then repeat a biopsy.
right,
So once the diagnosis is confirmed on biopsy, PET scan is the next step. That's a PSMA PET scan, which we now do. The sensitivity and specificity, means accuracy of those in layman term, is very good. And that is mainly for seeing distant spread, not the local spread. Because MRI will tell you the local architecture, the treatment planning it will guide. But the distant spread is by PSMA PET scan. So
right.
in that order, first PSA, rule out benign conditions, do an MRI, do a biopsy, and once proven in biopsy, then do a PET scan.
Scan, right. And what about then, once if you've confirmed, what are the treatment options? I've seen sometimes patients get confused because sometimes the advice differs, and I'm sure there's a reason for a difference in advice. Like sometimes they say, we'll do a little bit of radiation and chemo before the surgery, or sometimes they after the surgery this will be done. So there's a lot of confusion among patients about what's the right sequence.
So the irony is actually, the treatment is very well defined. In the earlier stages, when the disease is localized within the prostate, we go with a definitive treatment with a curative intent. But
Right.
once it is spread to the other organs, then it is a different story altogether. The definitive treatment is basically surgery or radiation.
Right.
So if it is totally localized to the prostate, then you can offer a patient robotic radical prostatectomy.
Right.
Or if the patient is not willing for that, or patient, the second actually definite option is radiation therapy, along with which we give hormone therapy also. So
Right.
these are the only two curative options, definitive options. Hormone therapy alone or chemotherapy is not a definitive option. These are chemotherapy is actually given in a metastatic stage when it is spread. Hormone therapy in definitive option is given along with radiation also. Now,
Right.
why I was saying it is an ironical situation, because in India, in not many hospitals, we do a tumor board meeting. We give all the options to the patient. So both the options should be given to the patients. You should do a tumor board meeting. The pros and cons of both the modalities are different. So you should individualize treatment for the patient. Suppose a patient has a large prostate along with
Right.
the prostate cancer. He has prostatic symptoms also, like lower urinary tract symptoms, frequency, urgency. Then
Right.
surgery would be a better option for him, because if you give radiation, his urinary tract symptoms would worsen. The side effects of radiation is like frequency, urgency, or those sort of. But if the prostate is not there and our patient is not having any of those symptoms, the disease is localized, then radiation can also be a very good option. So you need to individualize the treatment. You need to give both the options to the patient. Both the surgeon and a radiation oncologist should see the patient, and then ultimately it should be a informed decision. Hormone therapy before surgery usually is not given. There's no indication as of now. There are studies coming up to reduce, shrink the tumor or something, because hormone therapy, basically how it works is it reduces testosterone in males, and testosterone is a hormone which causes, growth of prostate cancer cells.
Right.
So to reduce that or shrink the tumor, sometimes it is given before the surgery, but it is not an indication. So we usually don't give hormone therapy before the surgery. But if you're talking of radiation, if the patient is not going undergoing radiation, then hormone therapy for 2 to 3 years is an integral part. So it can be given in form of injections every 3 monthly, or there are some different compositions. The duration of injections differ, so that. But once it has spread to the other parts of the body, then these treatments are not enough. Usually, these treatments are not given only if there is a large volume of disease in other parts of the body. Then you start with hormone therapy only to
Right.
reduce the burden. And according to the studies in last few years, at least one drug needs to be combined. So combination of two drugs, two different mechanisms to reduce the cancer drug. And the latest studies shows two different hormonal agents, I'm saying.
Right.
So, and according to the latest studies last year, which came, that if you are having visceral disease also, suppose liver is involved, then you need to give three combinations, which in the third one being the chemotherapy, which is
Right.
dosed. So the treatment depends upon stage to stage, but once it is localized to the prostate, then it is a curative intent. But if it is outside the prostate or gone and elsewhere in the body, then we try to control it.
Yeah. Doctor, just one related question to this. You said alternative radiation uh, plus and robotic surgery. So what are, if you can very briefly share, what are the pros and cons of each of these? And second related question was whether uh, in robotic surgery you remove the prostate. So you feel if it is localized, once removed,
So yeah,
it's totally permanent cure.
yeah.
But in
So
radiation, do you get a permanent cure?
no, both the things can give permanent cure.
Okay.
But yes, in surgery, we remove the prostate, we remove the lymph nodes also. So one important thing is to understand that now what diagnosis we have is on the basis of biopsy, like we discussed initially. So
Right.
biopsy gives us a Gleason score, or the grade of the cancer aggressiveness. But we have taken biopsies only from few areas, from designated areas according to template. We cannot take whole prostate as a biopsy tissue.
Right.
So when we remove the prostate and send it for testing, so there is a 25 to 30% chance of, upgrading or downgrading like that. So that once that is removed, and also we remove the lymph node. So the final authoritative, staging of the lymph node, whether it is positive or negative, is by surgical staging only.
Right.
Although MRI and PET scan are more than 95% accurate, but still there is 2 to 5% chance even in localized disease of having a micromets in the lymph nodes, and that is also removed in the surgery. So in radiation, we don't do that. We rely on the biopsy reports and the MRI reports and treat according to that. But the benefits and complications of both are different. Like surgery, we are removing everything, and then final report comes, and then we in surgery usually for a localized disease, we most of the patient, if it is low risk or even a localized disease is divided into low risk, intermediate risk, or high risk, depending upon the PSA value, depending on the
Right.
biopsy reports and all. So low risk and intermediate in localized disease, usually we don't require any additional treatment. Surgery
Right.
alone is curative. So we just follow up with PSA at 1 month, with the value should come down to very negligible one, less than zero point
Zero
0.2,
point. Yeah.
and zero point 0.2, and then every 3 months we follow it up with PSA. So if we know that if it is not come down to less than zero point 0.2, that there is some focus of the disease and the patient needs some additional treatment or something. But in the low risk stage or the intermediate risk stage, usually that is not the scenario.
Right.
However, in higher risk stage, when the PS is more than 20, or the disease has reached the prostate surface or gone a little bit beyond the prostate surface, then there is a 50% chance of requiring additional treatment. Then radiation is the treatment which is need to be given. So in surgery, there are two consequences. I won't say complications, there are two complications. Usually with robotic surgery, the benefit is that now we don't need to, patient to stay in the hospital for long. So when we used to do open surgeries years back, then we used to, have blood arrangement. Sometimes we used to counsel them regarding ICU stay, because prostate is a organ which is down in the pelvis, and
Right.
there is a bone in front and the space is restricted. So with robotic surgery, we now we can do the surgery with great precision, with great ease. We usually don't require ICU in 95% of the patients. We don't require ICU. We don't even arrange blood if the patient is hemoglobin is fine. And usually we discharge them in within 48 hours, and some of the patients have even discharged in 24 hours.
Right.
And they go home with the catheter, and the catheter comes out after a week or so, and we teach them exercises. And usually any significant complication is pre-op or intra-op or post-op is not there. But
Right.
there are two consequences of surgery. One is urinary leakage, because the prostate is situated just above the muscle which is controlling the urinary, having urinary control. So there is a weakness of that muscle, and then there is a urinary leakage. But 90% of the patients, even in our own experience, they recover this urinary from this urinary leakage in 1 year, and more than 50% within 3 to 6 months. There
Right.
are some patients who have very good continence even at 1 month also. So they
Right.
need to wear pads, but there are 5 to 10% of the patients even after 1 year who may have prolonged leakage. The second function is that prostate is situated behind the prostate. There are few invisible nerve fibers, which is neurovascular bundle, which may affect sexual function
Right.
temporarily. So the basic baseline function, it depends upon how the baseline function is, and if we are doing the surgery for low risk or intermediate, where it is only limited within the prostate, we go very close to the prostate and try and save those, neurovascular bundles. But because the surgery is being done in vicinity, so there is sometimes some effect. That also improves a lot in with time. But this is regarding the surgery.
Right.
So no significant complications as of now. These two consequences happen, and then the rates with which they improve, I've already told you. Radiation, we don't remove it. They don't have any leakage because we are not removing this
On the
thing.
prostate. Yeah.
But they will have, some urgency, frequency, sometimes blood in the urine. Radiation machines have improved a lot, so that the focus of radiation is given when the surrounding region does not receive radiation. The techniques also have improved. But some patients we see that those have, blood in the urine, or in the long term they may have cystitis, or they may have frequency, urgency. So these, in our experience, these we see these patients because when they have blood in the urine, they come to us as a surgeon. So usually after 6 months or 1 year, they have it. And then we try to treat them with whatever things are possible. So these are the complications. So if you have a patient who already have these symptoms or enlarged prostate, so that will not be a suitable patient for radiation.
Right.
But if the disease is outside the surface, I would say, or just close to the prostate but outside the prostate, then there's a 50% chance that after surgery the patient is going to require radiation. So it is better to offer them radiation upfront. Yeah.
Right. Any other general advice for the patients, do's and don'ts? At the end, I also want to ask you a couple of questions which were on the channel. So
Okay.
it'll be yeah.
So one thing I would advise to all the patients of prostate cancer or who have been diagnosed with this is a very slow growing disease. You don't need to panic in this. In fact, we have not discussed, but in the lowest of grades, the Gleason grade or earliest of stage of prostate cancer, there's an option of active surveillance also,
Right.
in which we just do a PSA testing and MRI 6 monthly and repeat a biopsy after a year, so as over treatment for these patients. Okay,
Right.
so but even if it is a not in that stage, a little higher up, but still localized, you don't need to panic. It's totally curable. We can cure it with either of the modalities which we have discussed, and patients have can have their normal lifespan. You
Right.
don't need to have any changes in your diet, in your overall day-to-day life. So you can just live your normal life. So you don't need to panic about that. But yes, if you're having raised PSA for long and you're getting it tested and you're not taking proper advice, or if the disease has gone out of the prostate and
Prostate.
affecting other then you should get medical advice as soon as possible.
Right. Just one question. What about the recurrence? In cancer, everybody is very fearful
Yes.
of the cancer coming back.
Yes.
So what's the success rate and what's the recurrence, if you could
So
share?
it depends upon the stage of the disease which we are treating. Like I said, so there are different types of recurrences. One is biochemical recurrence. In prostate cancer, we are discussing biochemical recurrence means PSA is started to rise again after we have done the surgery or we have done a radiation, PSA fallen down, and then it has started to rise again. So that is not as important as a clinical recurrence or metastatic. Biochemical recurrence precedes clinical recurrence.
Right.
So, but if you have a primary disease of a high risk prostate cancer, and then you have given treatment, and then disease is coming back, so then
Right.
the chances of having a clinical recurrence are much more as compared to having a point 0.2 value, a point 0.25 value, but localized disease. Then that can be treated with the additional treatment such as radiation after surgery or hormone therapy. So in localized disease, the recurrence rates are very low, but
Right.
in high risk or in locally advanced, the recurrence can
Can
happen.
happen.
Yeah, can happen, and then still patients can have a good quality of life and live for many number of years, unless it's totally a metastatic disease.
Right. So at the end, I would just like to ask the questions which are there on the channel. One, I think the common question asked is, what in the surgery, when its surgery is happened and the prostate is removed, what's the point of doing the PSA test? Because
So PSA is the only thing with which we follow up. So basically, we are trying to evaluate whether any prostate cancer cells because PSA is being released by prostate cancer cells.
right,
Okay. So we need to know that whether there are any prostate cancer cells left behind or coming back or growing somewhere else, or whether there is any focus anywhere else in the body. So that will be told to us by PSA only. Like I said, it will be a biochemical recurrence. PSA is a blood test, so you will not see on a MRI or a PET scan any lesion unless there's a visible focus, and
right,
the PSA will start rising many months before that. So there may be a situation that PSA is rising and you do an MRI and a PET scan and you don't see anything, but still you know that PSA is rising, so you may need to give additional treatment. But the other way around, doing a MRI and PET scan, there is a lesion, some focus uptake, and the PSA is normal. That is very very rare.
right.
So that is why that is the importance of PSA. PSA is the only test with which we follow up. The initial screening is also with PSA, and the follow up is also with PSA.
Just one last question. I don't know if I can read the names of the medicines very well.
Yeah.
The question was that University of Glasgow is giving nebendazole to
I
it's
think it's a mebendazole. That's a antiparasitic drug.
right to docetaxel
Yeah.
for prostate cancer.
Yeah.
So, any comments on that? I don't
So,
know.
no, so this mebendazole is an antiparasitic drug, but there is no use of mebendazole in prostate cancer. So it must be an investigational study.
Right.
Mebendazole helps in decreasing cell division by inhibiting in the cell division process. There is a microtubule assembly, and mebendazole inhibits that. So, and docetaxel is again a chemotherapy. So,
Okay.
to improve the effectiveness of chemotherapy, this is a hypothesis, but there is no mention of this drug in any of the guidelines. We don't use it. We don't discuss it in conferences. So, as of now, there is no role.
No. Okay.
Yeah.
So, Doctor, thank you very much. Really grateful that you could spare your time. And I think, I know you take care of other cancers as well, like bladder cancer. I hope we can have you discuss those at a later stage.
Sure, sure. Thank you so much, ma'am. Thank you for having me. I really enjoyed the talk.
Thank you very much.
Thank you.